So we're supposed to spend the next 2 hours talking. We'll see how much we get through or not. Oh gosh, Kristen's here, thank God. Now we can start, everyone. That's going to be on the final recording also, which will be great. So there's a handout for EKGs and things that you guys can look at, so that I made copies and you can all read.
We're going to edit this, so.
Okay. So I was supposed to talk about EKGs in the ICU setting and arrhythmias in the ICU setting. And this is sort of going to be just a combo talk for 2 hours. Though we'll talk a bunch about arrhythmias and ECGs, and then I just, at the end, just sort of threw in some interesting ECGs. I do have a 1% research support from a couple different companies for stuff, for whatever that's worth. All right, so our goals today is to learn a little bit about the ECG interpretation of arrhythmias, talk about how to manage a bunch of arrhythmias, understand the role of anticoagulation around cardioversion, and then talk about bradycardia on an ECG also, and not just tachycardias. All right, so what are you supposed to do for an arrhythmia? Check the patient's pulse, the first thing, and then get an ECG unless there is no pulse, and then call a code. Have you guys ever read House of God, any of you? Do you guys know this book? So this is it's written like 30 years ago now, maybe 40 years ago. And it's about a guy's intern year at the Beth Israel Deaconess, that's probably just Beth Israel Hospital in New York. And it's like the most sarcastic, bitter, everything you can think about an intern. But one of the classic things, he comes up with these like tenets, and the number one thing you're supposed to do at a code is actually check your own pulse. But it goes through all these like really just dark things like the Lasix dosing is supposed to be age plus BUN, and you get yourself a good dose. And it's the one that came up with the idea of like when you're putting the bed at certain heights, there's like the term orthopedic height and neurosurgical height, if you guys have ever heard that. Never mind. Okay, good book, very dark, very bitter, a little bit misogynistic actually, but really funny. All right, so when I approach an ECG, I go through like the same way I learned this in medical school, and I just eyeball it as just sort of the quick pass. I'm looking at every lead, I'm looking at every beat, the whole 10 seconds. Then I go through and I do those things of rate, rhythm, axis, intervals. I look at the P waves to look for hypertrophy or a chamber enlargement. Look at the QRS complex to look for bundle branch blocks, Q waves. The STT waves look for elevations, inversions, things like that. And then I will describe and then diagnose. So describe meaning it is a narrow complex tachycardia that is irregular with ST segment depressions. And then when I diagnose, I'll say it is Afib with a rapid ventricular rate with concern about ST depression suggestive of ischemia or something like that. And I think this is just a good way, whatever way you use your way, but just really be thorough whenever you're looking at the ECG. And then if we're specifically going to talk about arrhythmias, so my first thing is calipers. So if you're going to look at an EKG and try and figure out if they have an arrhythmia, break out your caliper. The other big thing about calipers, by the way, is if anyone ever asks you to borrow them, only hand them the calipers, don't hand them the top, because no one's going to steal your calipers without a top. That's my little, if there's one thing you take away from today, that's my message for you. So I use calipers all the time, and I would suggest if you're going to be in the ICU setting to get a set of calipers. And then the first thing is, are there P waves? So do you see P waves? Where do you see the P waves? Are they before the QRS? Are they after the QRS? Are the P waves and QRSs regular? And are there more Ps than QRSs, or are there more QRSs than Ps? And then is there a constant relationship? Is the PR interval changing or not? Then lastly, do the QRS complexes look different or the same compared to their baseline if you have that baseline ECG available? So is it wider or is it even narrower than what their baseline ECG looks like? All right, so if we get into tachycardias. So when I think about a tachycardia, I break it down into two things. Is it regular, irregular, is it wide, is it narrow? So once I break it into those, then I'm able to come up with my differential. So my regular, narrow complex tachycardias, the number one you're going to see is sinus tachycardia. Okay. And then the others are going to be either paroxysmal SVT or atrial flutter. So paroxysmal SVT is the AV-NRT, AV-RT, atrial tach, junctional tach, which is by far the least common. And then again, as I said, atrial flutter. Irregular narrow complex tachycardias, Afib will be by far the most common. So Afib is the most common pathologic arrhythmia. Sinus tachycardia is just the most common arrhythmia. But the other narrow complex irregular tachycardias are multifocal atrial tach, most commonly seen in those with pulmonary disease. And then someone who's just got frequent PACs. And then very rarely, SVT, atrial flutter, or sinus tach with Wenckebach or an atrial tach with Wenckebach will be irregular. And then your wide complex tachycardia, so monomorphic VT, AVRT. So you guys know with AVRT, that's the one with the bypass pathway. Most commonly, you'll go down the AV node and back up the bypass pathway, so that's irregular. But if it goes down the bypass pathway and then back up the AV node, that will be, excuse me, the first one was narrow complex, this will be wide complex. That's much less common, but you will see it sometimes. And then also the regular wide complex tachycardias are going to be any SVT that has a bundle branch block, or if they have a pacemaker, or if they have a bypass pathway or something. And then the irregular wide complex tachs are polymorphic VT, VF, or any of the irregular narrow complex ones that have a bundle branch block or pacing or something. Okay. So this is, when you're looking at tachycardias, this is by far the most important thing to do, is just describe it. Irregular, regular, narrow, wide. All right, so if we get into the narrow complex tachs, we're going to do some cases. All right, and you guys have your ECGs to look at here. So case 1, this is a 73-year-old woman who's actually admitted with pneumonia, and she reports the acute onset of shortness of breath, and this is her EKG. So if we had the audience response system, I'd make you guys hit buttons, but you guys can still look at that EKG on case 1 for a second there, and then figure out, do you think it's sinus, Afib, Aflutter, or atrial tach? And so take 30 seconds to look through it. Of course, I know you guys are all breaking out your calipers right now. I can see. If right. Oh, we have our teacher's pet right here. All right, so what do you guys think that this one is? If you take a guess. Fib, yeah, okay. So good. So this is a fib. All right, so it is a irregular narrow complex tachycardia. And it's actually not even very tachycardic here. But there's no clear P waves as you're looking at it, and that's one of the most important things. There are things that you see that you say, oh gosh, maybe that these are P waves, but you don't see a clear pattern to it. And things that you think are P waves, oh, by the time you get over here, things look pretty flat. So there's not one dominant sort of morphology, and it's a pretty constant baseline. When I'm trying to figure out if it's fib or flutter or an atrial tach, I try and ignore V1 a lot of the time because it may look more regular or more P-wavy in V1. And I'll look at whatever's down at the bottom in one of the rhythm strips. So you might have V1, you might have 2, you might have V5 down here. But here you get a good 10 seconds to be able to look and see, do you see a constant pattern? All right, let's go to case 2. This is a 61-year-old who comes to the ER with palpitations, and the heart rate's about 155. The blood pressure is normal. And this is the EKG for this person. And the question is going to be, what's this rhythm? As you look through it. And is this sinus tach? Is this fib? Is it flutter? Is it an ATAC? Or is this artifact? Okay, what do you guys think? Free to take. You're going to say sinus tach, flutter. Anyone else? Sinus tach. Got 2 with sinus tach, 3 with sinus tach.
I'm saying atrial flutter.
Flutter. Okay, so this is actually flutter, but it's really difficult to tell. So the heart rate's 150, which is one of the classic flutter rhythms, and you sort of have to say, why does someone come to the ER with a heart rate of 150 if it's acute onset palpitation? Sinus tach typically doesn't do that. But the key here is this ST segment depression and T-wave inversion in lead 2. And if you were to just like take away the QRS complex and just look at that, that really looks like a flutter wave. And so what you have is a flutter wave, and you have a second one that's buried in the middle of that QRS complex. So it's actually very difficult to see. And if you think that this is sinus tach, I wouldn't say to you, you're completely wrong at all. I can tell you that I know that it's flutter as we manage the patient further. But this sort of ST wave pattern, where things really look a little bit more sharp than you typically see with ST depressions in the setting of ischemia, you just have to think about flutter in your differential. And if you don't know, you can do things like vagal maneuvers to try and get the heart rate to slow down, or give them metoprolol or something, so that it becomes a little bit more obvious. Like if I were to have shown you this EKG, you guys would have said, oh gosh, there's this negative sawtooth pattern in lead 3 and 2 in AVF. This looks like flutter. It's much more clear. But I'm not going to give you the clear, obvious one. I want to make it a little bit more difficult for you so you learn. But you can see here, similar sort of thing here in this ST and T wave, that this sort of sharp deflection type thing in the ST very commonly is flutter, and especially if you have a heart rate of approximately 150, be thinking about that. Okay. So if you have someone who's coming in with fibr flutter, the first question is always, are they hemodynamically stable? Okay. So do they have hypotension, acute heart failure, angina, ischemia, chest pain, something like that? And if they do, and you're concerned about them, then cardiovert them, but please, please, please sedate them first before you cardiovert them. That's one of the take-home messages of today also, is do not cardiovert someone or shock someone who's awake. All right, get your anesthesia colleagues. Now, if they've passed out because they're so hypotensive, then yes, please shock them. All right, so if you have someone who's stable, then what do you do? Okay, and for most patients, they're actually going to terminate within 24 hours. So there are a lot of patients, they're probably not going to make it into the ICU, but you could ask the question of, well, do you really need to do anything at all if they go into Afib? So if you have someone who's severely symptomatic, that's the like angina chest pain person, then we already talked about cardioversion. But if you have someone who's rapid or they're mildly to moderately symptomatic, then yeah, I would treat them. I would try and make them feel better. And if they're asymptomatic, your goal heart rate is usually less than 110. Okay. There are some people that you may tolerate them being up to 120 or even 130 in some people. So let's say, for instance, you have someone who's coming in, they have acute heart failure, and they're in sinus tach at 110, and then they go into Afib, and their heart rate is now 120 to 130. Well, that 120 to 130 is probably hemodynamically what they need relative to a sinus tach of 110 to maintain that cardiac output. Right? So there may be people that you're willing to tolerate faster heart rates for. And then, again, if they're, let's say, go into Afib and their heart rate is 80 and they're doing fine, then I wouldn't worry as much about it. And please don't check a troponin in these people just because they've gone into Afib, right? Unless they have chest pain or something else. But Afib in and of itself is not an indication to check troponin. Because there's going to be people who's going to be admitted to the unit with rapid Afib, and someone's going to have to check the troponin, and it's going to be 0.07, and you're going to say, what do I do with this information? They're going at 140 beats a minute. So in general, for rate control, you'll be using the IV agents, so diltiazem, metoprolol, and esmolol. So diltiazem is the most common one that we end up using. A lot of the time it's because it can be used on the floor also. So you could, in the ICU, try and transition them, get them under control a little bit with a DILT drip, and then you could even transition them to the floor on that DILT drip. So it's a pretty easy thing to be working with. You can try and do some boluses of metoprolol, but it only lasts for a pretty short period of time, so it's not really a good reason to do it. And then if you have someone who, for whatever reason, can't get a calcium channel blocker, then esmolol is something you guys can use in the unit also. Rarely I've seen people use labetalol for this, but it's not the best rate control agent, and it does lower blood pressure a fair amount, so it's not something I would typically recommend. And then, once you're trying to get things under control with the IV portion of things, you're going to transition to something PO. And depending on their hemodynamic status, you may use one of the short-acting diltiazems, which is a Q6 hour, versus the longer-acting Q24 hour version. For rapid mode, we don't use too much around here. Diltiazem seems to be more preferred, but it's an agent that we'll use in some situations. And then you can use either the short or long-acting metoprolol, sometimes atenolol. And digoxin really doesn't have much of a role for the management of, I'd say, Afib in general, but especially not in the ICU setting. The issue is digoxin works really best for someone who's sedentary or elderly. You might use it for heart failure patients also, but it just doesn't provide much rate control for those people. Yeah?
How much IV DILT are you guys using?
So I would, depending on the situation, their hemodynamics, I would be typically doing a 20 milligram bolus, but if I'm worried at all, I might give a 5 to 10 bolus, and then I'll usually start at 5.
But is it common in your service to use DILT?
Oh yeah. I mean, not on my service because as an EP, I don't usually see the rate control patient, but yes, I would say diltiazem drips are pretty common on the floor for CARDS A. CARDS B, they don't get calcium channel blockers, the CARDS B patients, but yes, we use a lot of diltiazem. And it's used for what it's worth a lot on the cardiology consult service for patients who are on a surgery service or something like that. Okay. For talking rhythm control, the most common thing is going to be amiodarone. So you'll give the 150 milligram bolus, and then you can do, The classic thing for the drip is 1 milligram per minute for 6 hours and then 0.5 milligrams for 18 hours, but that doesn't mean you have to stop at 18 hours. Doesn't mean that you have to stop the 1 milligram at 6 hours, depending on the situation. You may want to load them more, but sort of the basics would be a 6 hour for 1 milligram per minute and then 0.5 milligram per minute. And you really want someone to have a central line or a PICC line or something like that. This is a patient who he went home and showed us the next day what his IV site had looked like, that he was getting an IV infusion, had thrombophlebitis. He also sent us a picture of his rectal abscess, which I didn't need to see, but he sent us that. I have no problem with it, except I'm an electrophysiologist and I don't really manage that. So there actually is a rule on some floors. They'll do a bolus of amiodarone but won't do a drip, depending on what the floor is. So that's something you may have to keep in mind if you're going to be sending someone out of the unit, that they may need a PICC line or something else if they're going to be on an amio drip. Sometimes the EP service will use some of these other medications, either flecainide or propafenone or ibutylide. So flecainide, propafenone you can give as a pill in the pocket, sort of an oral loading to try and convert someone out of AFib. And ibutylide, if you have someone who, the typical situation is someone who you want to cardiovert, but they don't either want to get a shock or there's some concern about giving them sedation, you can give them ibutylide instead to try and chemically convert them. The issue with ibutylide is that there's I don't know what the number is, 2%, 1% chance of polymorphic VT with ibutylide, so you pre-treat them with magnesium. They need to be on some sort of telemetry setting. So maybe like once a year we give ibutylide around here. But if you're going to do that, probably we should at least know about it. Anticoagulation for AFib. So we know that there's this increased risk of stroke after a cardioversion, a direct current cardioversion. So the issue is that when someone's in AFib and you convert them, electrically you look at their EKG and they have P waves, but mechanically their atrium is not squeezing fully yet. And so over the course of a day, a week, 30 days, the atrium, which was fibrillating, and then it starts to, you cardiovert them, they're back in sinus, and then slowly they start to squeeze more back to normal. And the thought process is that either during that time, or if they form a clot, or if they formed a clot before they were cardioverted, as they start to squeeze harder, that clot dislodges. So there's this increased risk of stroke that we talk about persisting out a month or 4 weeks. So if you have someone who's been in AFib for over 48 hours, they need 3 weeks of a weekly therapeutic Coumadin level documented, or you have to get a TEE on them to confirm that they don't have a thrombus. If they've been in it for over 48 hours and you feel like you need to acutely cardiovert them, give them a heparin bolus and an infusion and anticoagulate for 4 weeks. So if they're hemodynamically unstable, you feel like you need to do something or else they're going to die, do the shock, but give them heparin as soon as you can. If you have someone who's been in AFib for less than 48 hours, you don't need to anticoagulate necessarily. So if you have someone who's gone into AFib and you've documented they're in the unit, they're on tele, you know they went into AFib 16 hours ago, you don't necessarily need to anticoagulate them. But people who are felt to be highest risk, you may still want to. So like rheumatic mitral stenosis would be someone who you'd consider highest risk. Mechanical valves, those people you may consider highest risk. Or if you have someone who's had prior stroke, diabetes, high blood pressure, they're 80 years old, they're a woman with congestive heart failure, you may want to anticoagulate. Well, they should be anticoagulated anyway, but you may want to anticoagulate those people even if it's been less than 48 hours. Low molecular weight heparin and the new anticoagulants like dabigatran, rivaroxaban, those are okay. There is the occasional person that we may say they had 6 months in a row where they have been documented that their INR has been therapeutic, and you don't get weekly checks, but you just sort of say, gosh, they've been therapeutic for the last 6 months. Occasionally we may say that it's okay to cardiovert those people if it's felt to be necessary, but there's not a lot of data to back that up. So anticoagulation and amiodarone. Amiodarone can cardiovert patients. That's one of the things it does. That's why you probably have them on the amiodarone. The issue is, let's say you put them on amiodarone and 48 hours later, they're still in AFib. You haven't, let's say, put them on anticoagulation yet, and you still have them on amiodarone. Well, now you are doing something to actively try and convert someone without anticoagulation. So you need to reconcile that. So you need to put them on anticoagulation, Or you have to say, look, there's a risk benefit here and I can't anticoagulate them, but I really want to try and convert them. And so I'm willing to accept that risk, or the patient is willing to accept that risk. So even though we're not talking about a cardioversion electrically, a chemical cardioversion still has a risk of clot and thrombosis afterwards, or embolus afterwards. Okay, so that's actually a really, really important concept. It's something that we see done wrong all the time. Okay. All right, so any questions about that stuff before I move on? And feel free to interrupt me at any time. All right, so sinus tach. So you guys know about causes of sinus tach. Again, this is the most common arrhythmia you're going to see in the ICU setting. Things like fever, infection, hypovolemia, hypotension, anemia, and you can read the rest of this list. Hopefully you know a lot of this. In general, we do not treat sinus tachycardia. You treat whatever the underlying cause is. The one situation may be someone having an acute MI. So that person, you're still going to give them an IV beta blocker, their 3 doses, and then you may give them metoprolol. But you're not really treating the sinus tach, you're trying to treat the MI. That's the sort of underlying cause of it. Okay. All right, let's move on to case 3. 63-year-old guy comes in. He's having chest pain, but by the time you get him up to the floor, or he's come to 5 Southeast, he's not having chest pain anymore. And while waiting for a stress test the next day, he reports the abrupt onset of palpitations and mild chest discomfort. Again, pulse of 150, blood pressure of, that's pretty normal, and that's his EKG. So the question here is not what the rhythm is, but what are you going to do? So you can cry. It's fine. I give this talks, parts of this to interns. So a lot of them, when you actually do the audience response, it's like 25% say cry. It's great. Are you going to do that? You're going to call the attending. You're going to give metoprolol. You're going to give adenosine. Or you're going to do all of the above. What are you going to do? 3. So metoprolol for you. Metoprolol for you. You sort of started to do something. What are you going to do?
No, but I didn't really read. I
Okay.
wasn't really paying enough attention to the story. I'm hoping
Okay.
that they're not super hypotensive.
Now, so they have a normal blood pressure, but they're feeling chest discomfort again. Okay. All right. Metoprolol. So I would say all of the above are acceptable. I think you give metoprolol. I think you can call your attending. I think you can cry. I don't have a problem with that. In this person, we gave adenosine to try and figure out what this is. So this person is in a regular narrow complex tachycardia. And you do have a little concern that they're having ST depressions here, and relatively significant ST depressions when they're going fast, pretty diffusely. So probably this guy's going to have some sort of ischemic heart disease. But he's in some sort of SVT. I think adenosine is a good thing here because, number one, you're going to hopefully help get your diagnosis of what this is. Number 2 is you might terminate whatever the arrhythmia is, depending on what it is. And you might make them feel better with that. So we actually gave this person adenosine. And this is the response we saw. And of course, he's got the positive arrow sign to point to the P waves. So this was someone who was in an atrial tachycardia as their underlying cause of what happened. And it's actually interesting. I've never looked at this part of it before to see what happens to the ST segment here as you slow down. And you do have less ST changes when their heart rate is slower. Of course, the thing about adenosine is if we had kept on going with an atrial tachycardia, if we had kept on tracking the EKG around, they started to go back again at 150. So in that situation, then I would say, okay, yeah, sure, give them metoprolol is an option. And it's someone who you may actually consider cardioverting someone like this even, because they're having chest pain, they're having ischemic EKG changes. So it's just something to consider for someone like this, depending on the situation.
But wouldn't metoprolol have reduced the heart rate, and you would have been able to possibly see what the underlying?
Possibly, but it's going to take a little bit more time.
Okay.
And metoprolol may not work for something like this. Because the issue is this, is that, so if you're giving metoprolol, what are you trying to do in that situation? You're probably not going to slow down the atrial tachycardia itself. What you're going to try and do is be slowing down in the AV node. Right? So you're going to try and take something that's having a 1-to-1 conduction and make it 2-to-1 conduction. And so metoprolol may work for this, but it may not work for this. So I think it's totally reasonable to give it a shot. And if the guy is, he's having chest discomfort, but it's not the worst thing in the world, totally reasonable to give him metoprolol. This is just an example of another regular, narrow, complex tachycardia with some EKG stickers that's not on very well. And with something like this, the first thing you're going to try and do is find the P wave once you've tried to establish that it's regular, narrow, complex. And so the P wave here is a little bit difficult to see, but it's actually that little, quote, S wave here in lead 2. So that's an inverted P wave here that you're seeing. And this R prime, it sort of looks like a right bundle branch block, but it's not a right bundle branch block. Those are P waves that are buried at the end of the QRS complex. Okay. So this is the sort of person, again, you would give adenosine for. And this rhythm would terminate because this is AV-NRT. Not that you need to know that specifically. But AV-NRT, AV-RT are going to terminate with adenosine. Atrial tachycardia, atrial flutter, 99 times out of 100, those are going to persist. Okay. So someone like this, I would do adenosine for. Yeah. Sorry, yeah.
When I'm looking for P waves in this,
Yeah.
I don't know why you wouldn't say that that little P wave looking ditzel in lead 2 is not a P wave.
This thing?
Mm-hmm.
Yeah, because it's not, I don't know. How would I say this? It just doesn't look like one to me. I know that's not a good answer. I know that's not a good answer. But it's a little bit too flat in lead 2 to be a real P wave. Usually if it's, now, depending on if it's an atrial tachycardia where it's coming from, it may be more flat. But you're not seeing it repeatedly in every lead. And then what would I don't know. I don't have a good answer for you besides what I would say is you give adenosine and you're going to stop the rhythm and you're going to see that your QRS is going to change and look more narrow. And that's how I would also argue that that's a retrograde P wave. You're right, though. You're right. You look at that and you're sort of like, well, that looks like a P wave, but it's really just the end of the T wave.
And it marches out, right? You would march it through and do about the same.
Yeah, this probably would march out, though, also.
Yeah.
That end of the T wave. But no, you're actually really right. The more I look at this one, I would confuse myself, but I also, I know, I took this person in the lab also, and I know. But also, it's like, but it's also this classic thing. I'll tell you, when you compare their baseline EKG to this, where they have that sort of, it's called a pseudo R prime here, and when you see their baseline ECG, they don't have it. That's so classic for AV-NRT.
And when you give people the AV-NRT adenosine,
Yeah.
then they...
So they should stop, and that quote P wave is the last thing you see before the QRS, but it may not be. You may get a QRS with no P wave.
Yeah, so you're going to have CA systole.
Yeah. Well, you'll see complete heart block. You'll see, you stop the arrhythmia, the P waves, sinus P waves come out, and you have heart block for a little bit. And then it comes back again. Hopefully you guys have all... Right. So hopefully you also talk to the patient ahead of time, and what I usually tell them is you're going to feel like you're dying for like 5 to 10 seconds, and then you'll feel a lot better. Or I'll say like you're feeling like crap or something like that. But you sort of lay it to them straight, but you say you're going to feel better after this. So these people, again, adenosine, 6 milligrams, 12 milligrams. You can give 12 milligrams another time. There's some situations that I may give even 18 or 24 if it's not working for whatever reason. If they have a central line, push it through that, and really, you want to be fast. You want to push and then push the saline. Vagal maneuvers you can try also. So either have them do the Valsalva maneuver, push on their carotid. We used to talk about doing like ocular massage or ocular pressure, but then some people ruptured eyeballs, and so we don't recommend that anymore. You can also dunk their face in ice water. This is one of the classic ones. And then if it's incessant or whatever it is, you can use beta blockers. You can use calcium channel blockers. So this is one of the things people will say, oh, I don't want to give them a beta blocker because I know their baseline ECG shows Wolff-Parkinson-White, WPW. And that's only in the long run as a preventative agent. You don't want to give them beta blockers or calcium channel blockers. But if you have someone who's acutely in SVT, you're trying to break their arrhythmia, the AV node is one of the limbs of that arrhythmia, you can give them a beta blocker, you can give them a calcium channel blocker. Okay. So in the acute setting, you can give metope, you can give verapamil, you can give them DILT. Occasionally, you might give amiodarone. Rarely would you guys ever give procainamide. And then cardioversion is an option if you have someone who's unstable. Okay. But please, whenever you're doing any of these things, have them hooked up to an ECG, have them hooked up to telemetry, like show me the rhythm. Because I'm not going to believe you, whatever you tell me. All right, document the rhythm. Yeah.
Kind of wish I was off tape, but
We can turn it off for you.
one of my problems with the term SVT
Uh-huh.
is that it seems like anything that's narrow and fast is an SVT. And so, like, when people are like, oh, my patient's an SVT, and
Uh-huh.
then you're like, oh, well, that's flutter, you know? I mean, like,
Right.
I feel like fib and flutter is in the SVT basket until it's pulled out of the basket.
Yes. No, that's actually not a stupid question. That's actually a really important question. So what I'm talking about
that was
here,
very boom.
yes. So
Just joking.
So what I am talking about here are the paroxysmal SVTs. So the paroxysmal SVTs are AVNRT, AVRT, junctional tachycardia, atrial tachycardia, and then some things like Maheim tachycardias that we're not going to talk about. Atrial flutter, atrial fibrillation are SVTs, but they're not paroxysmal SVTs. So technically, yes, flutter or fib are supraventricular tachycardias. But when we say SVT, we're typically talking about the paroxysmal ones.
Okay.
Yeah. But that is actually an important distinction that I didn't make clear. All right, let's go to case 4. These are 2 patients who have the same diagnosis. What is the diagnosis that this person has or people have? I'll just tell you the top one here, these are 2 ECG leads. This one, it's an ECG lead and a pulse ox on the bottom. And so is this artifact, is this atrial flutter, is this atrial tachycardia, or is this ventricular tachycardia? So we have artifact.
Toothbrushing syndrome.
We have toothbrushing syndrome. Right, so good. You guys actually have done better than any other group I've ever shown this to.
Toothbrushing syndrome.
So both of these are artifact. All right, so if we look at the top one here, this is sinus rhythm, right? P wave, QRS, T wave. And you go along, and then they start to have this high frequency signal that you're like, what is this? It doesn't, like, it's so sharp looking, it almost looks like a mini QRS. It doesn't look like a P wave in any way. It is sort of regular, but it changes morphology. But the thing that's weird is if this was, let's say, atrial flutter or atrial tach, the QRS rate doesn't change. So why would you go into an arrhythmia and yet the QRS doesn't change? Right, so that's sort of weird. If we look at the bottom one here, if you look closely at this, or maybe not too closely, you can see that there's a QRS, a QRS, a QRS, dun, dun, dun. So there's something marching out that you see through this, plus the pulse ox here really helps you. Right, so if this was, let's say, VT, with each of these things being a ventricular complex, like this should be either like this or like that or something. But here you have a nice QRS complex, and all these little bumps here are because of the toothbrushing, which this person was actually doing. And if this was fib or flutter shouldn't be causing noise on the pulse ox, right? Because the pulse ox is representing the ventricular contraction and flow throughout the body. So you don't get noise on the pulse ox with fib or flutter. So in the unit setting, patients are going to have SWAN, so they're going to have pulmonary artery waveforms, they're going to have arterial lines, they'll have pulse ox. So if you have something that you don't know if it's a ventricular arrhythmia or not, use those ancillary things to help you figure out what it is. Because I get called about this all the frickin' time. All right, and say this person had VT, and then you look at it and you say, all right, we're not doing a consult, this is artifact, forget about it. All right, good, that was a great job. You guys did, as I said, better than anyone else. All right, so we've talked about narrow complex tachycardia. Let's get into the wide complex ones. So a 35-year-old who has a history of nonischemic cardiomyopathy, and they have palpitations, and then this is their EKG. So the question here for this one on case 5 is, what's the diagnosis? Is this AFib? Is this A flutter? Is this sinus tach? Is this VTach? Okay, so we have 1 for sinus tach. Sinus tach with a left bundle. Okay, so 2 with sinus tachs.
I'm going to go with that too.
3 with sinus tachs. 4 with sinus tachs. 5 with 6.
I implied there was a left bundle.
Okay, I know, I understand. I'm ignoring the, she said, yes, I'm ignoring that. So we have 6 people sinus tach, and we have 1 abstention. So, you guys are wrong. This is,
You are?
yeah, this is VTach. So this is 114 beats a minute, and this is a regular wide complex tachycardia. So the first thing you're going to do is, first off, check the patient's pulse, be sure they have one and that they're breathing and that they're talking to you, which this person is. And then you're going to look at it and you're going to say, do I see the P waves? Right? And when you see, and then you're going to have someone who's going to point out to you with the positive arrow sign, there are the P waves. So you have a P wave right here. You have one right at the beginning of that QRS complex. You have one buried in the ST segment, one on the top of the T wave. That's why that T wave is taller. On the downslope here and there and so on. So here you have a ventricular rate of 114 beats a minute, but a sinus rate that is, I don't know, 60, 50 beats a minute. So here you have VA dissociation. You have more QRS complexes than P waves. This is a slow ventricular tachycardia. All right, because you're not seeing here like P waves in front of the QRS complex. You have a P wave there and a P wave there. But you're not seeing regular P waves in front of the QRS complex.
Baby, like, tiny ones in V2. Right?
Yeah, exactly.
Tiny ones in V2, right. So that actually is part of the QRS complex.
Okay.
So people have VT at this rate?
Oh, yeah.
I mean, like when they're not on like 60 meds?
So most commonly, this is going to be someone on amiodarone. So amiodarone, one of its classic things is it slows VT rate down, in addition to hopefully terminating it. But if you have someone who's got a lot of scar in their heart, really sick hearts, you can have VT that's this slow. So there is someone who spent, I don't know how many weeks on 5 Southeast, ended up having a balloon pump for a while, had an Impella for a little while, but he had a VT that was actually at 90 to 95 beats a minute, and we couldn't ablate because it was epicardial and he'd had a couple prior cardiac surgeries. And so what we did was we then started to pace. He had a defibrillator, so we paced him at 100 beats a minute to suppress his VT, and then his VT actually started to get a little bit faster and would go up to 115 and things like that. But yes, you can have someone who's walking, talking to you with VT at 115 beats a minute with a normal blood pressure, and it can be this slow.
You mean you couldn't ablate him because his scar was epicardial?
Yeah, the focus of the VT, the circuit from it was on the epicardial surface. And so you can get an epicardial stick and you can go into the subxiphoid and you can get into the pericardial space. But if you've had somebody who's got prior cardiac surgery, then that the pericardium is all adhered, so you can't get a catheter in. Plus, if you've had bypass grafts, you might like knock off a bypass graft. Is another concern. But plus, this guy, it's sort of a complicated story for him.
It's scary that I would have taken care of him for a few days and not known that.
So, but that's why I show this to you to get you guys thinking about it. Okay, so VT can be slow. The other thing about this is that you have what's called negative concordance here. So all the QRS complexes are negative in V1, V2, V3, V4, V5, V6. So the precordium, the V1 to V6, if they're all negative or all positive, that goes along with it being VT. Usually with a left bundle branch block, the QRS will be positive by V6. It's not always true, but usually it'll be like that. So, but the key here is that you have more QRS complexes than P waves. That is 99.9% of the time VT. Another thing you may see sometimes is something like this called a fusion beat. So here they're in VT, but you have this one beat that I've helpfully circled, which looks different than all the other ones. And that's because it's a fusion of a normal sinus rhythm beat that just happens to come in. So they have a P wave that you can't see here that goes through the AV node and comes down and tries to capture the heart. At the same time, you have the VT come in. And so that fusion beat is the sort of the love child of a narrow QRS complex and a VT beat. Okay. Sometimes you may see what's called a capture beat, which is just a pure narrow complex beat in the middle of it. I don't have an EKG of it. Just another example of concordance. So before I showed you where all the QRS complexes were negative in V1 to V6. Here they're all positive in V1 to V6. And this person's going really fast, and yet you don't see chest compressions on this. So they were enough of a blood pressure that they were awake and talking to us and we could get this EKG. If you have someone in VT and they are awake and talking to you, getting an EKG of it is really, really, really helpful to me as an EP. Because if I'm going to take them to the EP lab for an ablation, I want to know what their clinical VT looks like so that I can try and ablate that rhythm when I have them in the EP lab. So a stable patient, if they're unstable and they need to be shocked, we'll shock them. But if they're stable enough to get an EKG, please do it. So the hemodynamically unstable patient, do your ACLS algorithm and shock them if you need to, give them amiodarone. The hemodynamically stable one, please don't shock them. And again, don't use your hemodynamics to make your diagnosis. So if someone is awake and talking to you, that doesn't mean that it's not VT. And if someone is passed out, it doesn't mean that it's not SVT. Okay? Use your EKG and sort of figure out what you can do with that. If you have someone with VT, let the EP service know. And then typically the first thing you're going to do is give them amiodarone. So it's 150 milligrams. If it's the VF, then it's 300 milligrams. Doesn't mean you can't give someone 300 milligrams in VT, but typically we would give 150. And then again, we'll do a drip. If they're still having recurrent events, lidocaine is typically our next drug that we use. So give them a 100 milligram bolus. Give them 1 milligram per minute is typically what we'll start at. And then we'll check levels daily. So just make sure if you have someone on lidocaine that you're checking daily levels with him. Patients who get lidocaine toxic, typically it's neurologic. They get mental status changes. They start to have nausea. They get really crabby and agity. If you can give them a beta blocker, do that. But oftentimes they have profound heart failure and you can't do it. If they're having recurrent events, we'll put balloon pumps in them. We might put Impellas in them. And then lastly, if you're someone who's really having a lot of VT, it's not the intubation, it's the paralyzing. So you're trying to get rid of all autonomic tone as much as you can. So you're trying to essentially sedate them so deeply that they can't maintain their airway, and so that's when you're going to intubate them. So there are some people that we will, even though they don't meet criteria for intubation from a pulmonary perspective, they just, you need to sedate them so heavily they can't protect their airway. And then in the long term for these people, well, you'd want to try and get them on beta blockers if you can. That's the best agent. If you can discontinue their inotropes, like these people who, I don't know, there's someone upstairs who is having VT and he's on a balloon pump and he's on high dose dobutamine, well, we can give them amio and things, but there's not a lot more I can do. It's sort of make their heart failure better, get them off the dobutamine or milrinone. In the long term, we'll talk about putting an ICD in these people. Amiodarone, PO we might be doing. And so you want to try and get about 12 grams or so into them as sort of a loading dose. So combined with your IV, here's just an example of, for VT, you might give them 400 milligrams TID for a week, and then 400 BID or QD for a week, and then 200 milligrams daily. But for most of these people, we're trying to get them to a dose of 200 milligrams daily as their sort of maintenance dose. And then in the outpatient world, we'll lower them to 100 or try and get them off of it if we can. Patients, you want to try and get a baseline TSH, liver function tests, and then they either need pulmonary function tests or a chest x-ray at baseline. Mixilotine may be an adjunct that we'll use in addition to amiodarone. Mixilotine is a poor man's version of lidocaine. It's not as good as lidocaine, but we'll use it as an adjunct to amiodarone for another agent. We have used ranolazine at times also. So ranolazine we typically think of as an anti-ischemic, to help for angina, but it can also be used as an antiarrhythmic. It's okay. It's not great. It's rarely the thing that's going to save them, but it's sometimes something we'll use, especially if they have an ischemic cardiomyopathy. And then, if we're still having issues, we might be going to procainamide. There's no PO form of it anymore, so we'll just be giving IV procainamide. Dilantin, phenytoin is an antiarrhythmic also. Rarely we've used that if we need to. And then ablation, depending on the situation, we might be doing that. And then, so in rare circumstances, we've done this left cardiac sympathetic denervation. I don't know if you guys have ever heard of that. The thoracic surgeons will go in and try and remove part of the sympathetic chain on the left side, which is essentially some of the nervous sympathetic input into the heart. So it works really well for long QT syndrome, and it works really well for CPVT, catecholaminergic polymorphic VT, which is something that kids or teenagers get. But it's been used for ischemic and non-ischemic cardiomyopathy also. And it's a temporizing thing to see if it might work. We've had the anesthesia service come in and do a bedside bupivacaine injection. So they'll just at the bedside, they'll do an injection of the sympathetic chain under ultrasound. And you can sort of see if that works and whether it's worth it to do a bigger procedure for them. Most of the people that we've done this for, they're so sick that by the time we do it, it doesn't really do much to them. In the unit setting, if you have someone VT and they have a device, that we might do anti-tachycardia pacing through their device. So I don't know if you guys know about this or not, but ICDs shock, but they can also sometimes pace someone out of it, out of their arrhythmia. So if you have someone who's in VT at, I don't know, that's relatively slow, but I can't read exactly how fast that is, but this is, let's say, 110 beats a minute. You might try and pace them at 120 or 130 beats a minute, just a little bit faster than their VT. And a fair amount of the time, you might be able to get them out of the VT without shocking them. So this acutely terminates it, but doesn't, of course, prevent the next episode. Okay. Occasionally, there's a couple of these normal heart VTs that you may see. So people who have no cardiomyopathy, there's nothing wrong with their heart, but they may have this. This is paroxysmal RVOT VT, so the right ventricular outflow tract, the area just below the pulmonary valve, is an area in some people that's more arrhythmogenic, usually young women, but it doesn't have to be young women. And so people like this, they either have paroxysms or they're just constantly in VT for a while. There's another one where you have people who it comes from the left ventricle and they have this VT. So this was a 19-year-old kid who's going really fast. This is like 200 beats a minute, and he's sitting there talking to you in the ER and feeling uncomfortable. This is also called verapamil-sensitive VT, for what it's worth. You treat it with verapamil. So just so you're aware of these sort of normal heart VTs that you may occasionally see. Yeah?
Can you just one more time
Yeah.
go over left versus right? I mean, I see the positive versus negative deflection in like V1, V2. Are there other ways of knowing exactly where it's coming from?
So yes, there is. The key whenever I'm looking at VT and trying to figure out where it's coming from, what's the substrate like, is it a left bundle branch block pattern or a right bundle branch block pattern? So you look at V1, V2, you look at V5, V6, and here it's positive in V6, it's negative in V1, so that's a left bundle branch block pattern. It tells me it's almost definitely coming from the right ventricle. That's in contrast to this, where it's positive in V1, negative in V6, so that's more of a right bundle branch block pattern, and so it makes me think it's coming from the left ventricle. So if it looks like a right bundle branch block, it's coming from the left ventricle. If it looks like a left bundle branch block, it's coming from the right ventricle. That's sort of the general principle. So that's the first thing I look at when I look at a VT. That's not true. I look to see if there are P waves. And then once I look to see if there are P waves, then I look to see what the morphology is. A lot of the patients in ICU have PVCs, and they might have frequent PVCs. This is by Gemini. Question is, well, what do you do with PVCs? So if the patient is asymptomatic and there's nothing going on, most of the times I usually just leave it alone. If someone is symptomatic, the first line for therapy is typically beta blockers for something like this. Sometimes you might use verapamil actually for that like verapamil sensitive one we talked about. Antiarrhythmic sometimes. You can check the labs. People say, oh, well, let's check their labs. Let's look at their potassium is. But like, that's not what caused the PVCs. They have a heart that wants to go into this. But sure, fine, check your labs. Turn off telemetry. That's what I recommend on the floor, but you guys can't do that in the unit. And then if you have someone who's symptomatic from the PVCs and they're failing therapy, or if their ejection fraction is going low and you think it's because of the PVCs, we might do an ablation for someone like that.
What's the burden usually that you'll ablate?
So if I have someone who's got a normal heart and no drop in EF, sort of 15 to 25% is sort of the cutoff thing. If I have someone who's got a low EF, I might be like at that 15% mark, maybe more likely to do it, because there's some data that says if you ablate these people, you can improve their EF. But I also have people who say, I really don't want an ablation, I don't want anything, and they have had like a 40% burden. And it's like, well, you can't force anyone to do anything. All right, polymorphic VT. This is an example of what it looks like here on an EKG. This is my only EKG I have of polymorphic VT, and I don't know why there's not chest compressions going on in the middle of this. So if you have someone who's in polymorphic VT, so do your ACLS algorithm, shock them. Typically magnesium is something we talk about doing for these people. But the key is that when they're not in VT, you want to know what their EKG shows. Because the two most common causes of polymorphic VT are they're going to be ischemia or long QT syndrome. So if you have someone who's ischemic, you want to look to see what do their ST segments look like, what are their T waves. And if you have someone who's got long QT, you want to see what their QT looks like. Magnesium only works for the long QT syndrome people. It doesn't work for ischemia. It's not going to cause harm probably, but it may not help. If you have someone with polymorphic VT, let us know about it. And then depending on the situation, we may recommend a beta blocker or isoproterenol. And that's a beta agonist. So depending on the situation, we may say beta blocker or beta agonist. We may say put in a temporary pacer. Depending on the situation, we may say do an ischemia evaluation. And then if you think that they're having long QT syndrome, I don't know if you guys know this website, torsade.org, takes you to the Arizona CERT, whatever it stands for. But it has a list of QT prolonging drugs, so you can try and avoid those. For what it's worth, there's also a website called brugadadrugs.org for people who have Brugada syndrome. You can look up to avoid those drugs. So polymorphic VT, just think about, is it ischemia or is it long QT? Okay. And then VF. So here's a nice ECG of VF. So I actually have a lot of ECGs of VF now because of the LVAD patients. So the LVAD patients, they can be in VF and they may or may not know about it. They may usually just feel sort of a little funny. Sometimes they'll pass out, but sometimes not. And as long as they have low pulmonary pressures, they may be okay for a period of time.
Do you have the one from Tacoma
That says LVAD artifact? Oh, yes. Yes. They said LVAD artifact. It was not an LVAD artifact. It was VF that guy was in. So, so people, if they don't have a LVAD, shock, chest compressions, ACLS, don't bother getting me an ECG unless they have an LVAD, and then don't do chest compressions and all those other things. Okay. So we had this guy, here's our little, I know it's going to be an hour almost of doing this. So there's an LVAD patient who had VT a couple weeks ago, and there was whoever's covering the Surge C service at night. He's talking to our EP fellow, and he's like, the guy's in VT, I'm just going to shock him. And then you hear the patient in the background, hold on, wait a sec. It's like, don't like sedate someone if you're going to do it. It's like wide awake. Anyway. All right, there's our, are you guys doing okay? Need a little break? All right, we'll keep going. Let's talk about bradycardia then. All right, so there's a bunch of different things that can cause bradycardia. You can have sinus bradycardia. So with this, you have a P wave in front of every QRS, and that the rate is slow, less than 50 to 60 beats a minute, depending on the situation. You can have type 1 second degree AV block, also known as Wenke block. So you have a P and then a QRS. The PR interval gets longer, but still have a QRS, P, QRS with a longer one. P wave, dropped beat, no QRS complex. And then your PR interval comes back again and it's shorter. So typically what I will do in this situation is I will just look at these two beats. And I'll say, is this longer than this? And if it is, because that's where you're going to see your greatest difference, if those two are, then that is Wenke block. All right, Wenke block is going to be by far more common than your type 2 second degree AV block. So here, this PR interval is the same as this, is the same as this, is the same as this, and then it drops, and then your PR interval is unchanged the whole time. Also with this, you'll notice that they have a right bundle branch block at baseline. So you don't know, is this dropped beat because there's poor conduction in the His-Purkinje system, or in the His bundle, or is it because there's a block in the left bundle occasionally? So maybe right bundle, right bundle, right bundle, both bundles. That's a possibility. Frequently, you'll see this 2-to-1 heart block. So P wave QRS, P wave nothing, P wave QRS, but that these P waves actually march out. And this you can't tell, is it Wenke block or is it type 2 second degree heart block. You can have them walk around, and if you walk around, you might see more conduction. So you might see 3-to-2 conduction, or you might see 3-to-1 conduction. That helps you out. So complete heart block or third degree heart block. So here you have a QRS rate that's constant, and you have P waves that are constant. Oh, they're technically not quite true, but ignore that for right now. Sometimes your escape rate may be a little bit slower than others. So this person, I'm surprised that there's not more going on, like, again, CPR or transcutaneous pacing or something, because this is an exceedingly slow heart rate. Sometimes you may have Afib with a really slow ventricular response. I don't know how long that pause is, but that seems to be pretty low. And then occasionally you may see something like this called paroxysmal AV block. So here they're going along, everything looks fine, and then they have a PVC comes in, and then they actually have heart block for a little bit until they have another PVC. that causes things to go back again. All right, so let's look at case 6. So case 6 that you guys have there. So the question is, where is the level of block on this one? So is there a disease of the sinus node, of the AV node, of the his Purkinje, or really there's block? What do you think? Answer 4? AV node, okay. We at least have one answer. So what I would say is, it could be AV node. I highlighted his Purkinje, but it's probably either AV node or his Purkinje. So this is regularized Afib. Right, so the person's in Afib, because you don't see clear P waves and you have that undulating baseline, but the rate is regular. Right, so Afib is irregular. So the only way that you get regularized Afib is you have complete heart block and you have an escape rhythm that's regular coming out. Okay. The two most common situations you're going to see something like this are in the cardiac surgery population, so post-aortic valve replacement, let's say, or post-TAVR, where they develop complete heart block and they also have Afib. Or DIG toxicity is the other situation when you'll see this. So DIG toxicity can cause like any arrhythmia pretty much, but regularized Afib is one of the things that you see in DIG toxicity. So they're on DIG because of the Afib and then they become toxic and they develop heart block with an escape rhythm. So this is one you don't want to miss, that you don't want to miss the heart block, but it's relatively common that we'll see something like this missed a couple times a year. So when we talk about bradycardia, we talk about the management of it. We're thinking heart rates less than 40 most commonly, sort of a cutoff number we use. And then the big thing is, are they symptomatic? It's like everything we're talking about. So they have mental status changes, hypotension, blah, blah, blah. And is it an acute change in their heart rate or chronic? Are they chronically at a heart rate of 43 because they're an athlete or something like that? And are they sleeping, and do they have sleep apnea? So if someone has a heart rate of 20 while they're sleeping, if someone develops heart block while they're sleeping, I'm not going to put a pacemaker in them. I'm not going to do anything about it. I'm going to tell you to turn off telemetry. But again, they're in the ICU. You can't do that. But a lot of bradyarrhythmias happen while you're sleeping because the person is high vagal tone. And so we don't really want to treat those things. And even, just as a general comment, not everyone with bradycardia, even complete heart block, needs transcutaneous pacing, needs transvenous pacing. They'll probably need a permanent pacemaker. But if you have someone, let's say, who's in complete heart block, and they have an escape rhythm that's narrow, complex, in the 60s, we want to know about it, and we want to put a pacemaker in them. But doesn't necessarily mean that they need a temporary wire. If they have a wide, complex escape rhythm, then those are the people that we're going to talk about would need a temporary wire. Or if their heart rate is slow, or if they're symptomatic. And slow, I don't know how to define, less than 40 maybe. If you're going to transcutaneously pace someone, please sedate them. I don't know if you guys have ever done it before, but it really hurts and it's uncomfortable for the patient. You might give them atropine, but if someone's had a history of a cardiac transplant, it actually can make things worse. So don't give atropine to a transplant person. Don't ask me why, I don't understand the pharmacokinetics or whatever it is. And then you can try dopamine, epi, isoproterenol, some sort of beta agonist as a temporizing measure. If the reason that they have heart block is because they've done a beta blocker overdose, which we don't see much here, that's really Harborview sees things like that. Glucagon is the antidote for that. And then again, transvenous pacing. So the cath lab is the ones here that do transvenous pacing. So you want to get them involved to do a transvenous line. Or I don't know, maybe you guys are going to do that upstairs on the floor. You could do that if you wanted. All right, so we're done with part 1. And so the keys things here is just going to be get an ECG of whatever the arrhythmia is, make me happy. And then if they're tachycardic, don't use your hemodynamics to make your diagnosis. Think about if it's wide or narrow, regular, irregular. Oftentimes beta blockers or calcium channel blockers is what you'll use for tachycardic rhythms or amiodarone or cardiovert. And if they're bradycardic, what's the level of block? Are they symptomatic? Do they need transvenous pacing? So, yeah.
Can you talk just briefly about amiodarone and Seroquel and drugs like this and QT prolongation?
Yeah, so QT prolonging drugs. Amiodarone and dronedarone, Multac, but really amiodarone, so amiodarone is the only drug that prolongs QT interval but doesn't lead to torsade. And it's sort of a complicated reason. But all the other drugs that you think about as being QT prolonging agents are going to be promotion of torsade or risk of torsade. So things that are going to make you the patient's going to be more likely to be at risk for developing a QT prolongation that's going to put them at risk of torsade would be QT prolonging agents that are IV versus PO, multiple drugs, drugs that are pushed versus a drip, women, acute disease, so if they're in the hospital, obviously they have some sort of acute disease, someone who has a history of coronary disease, heart failure. That's a lot of things I can think of off the top of my head. If someone has a QT corrected interval over 500, you're going to be more at risk. But there's no like safe risk. If someone's 470, they may still be at risk. You may just have to accept that risk depending on the situation. Does that answer your question?
Yeah, I've not really seen anyone go into torsades.
Yeah.
Like when we've treated even, EKGs that have a prolonged QTC, and we give Seroquel, for instance, and so I just wondered.
Yeah,
about that.
I'll tell you the two drugs I always get worried about, because I'm an EP, would be sotalol and dofetilide. So those are going to be drugs that are going to prolong the QT interval. So I'm a little bit more cautious giving multiple QT drugs with that. But frankly, like if you guys are in the unit, they're so monitored there that I'm not saying to do it, but at least they're in a more closely watched setting. So if something does go wrong, like nurses or whoever is going to be right on top of it. All right, so yeah.
One more recap.
Yeah.
So, sleep, once again.
Yeah.
Like, you don't really care, heart block, whatever.
Mm-hmm.
Like,
I would say commonly I
Right,
don't.
sleep.
Yes.
and there's nothing to that, it's only.
Yes. Although what I would say is that if I have someone who's having episodes during sleep, my most common thing is I will ask questions about sleep apnea. Now, mind you, if someone's having like 2 hours of complete heart block while asleep, all right, well, that's abnormal. I'll at least say that much. But if it's like 5 seconds, I don't think much about it. Now, you guys may still want to get us involved to sort of like cover your butts and say, well, we spoke to EP and they said everything is fine. But most times I'm going to say it's fine. All right, we're just going over EKGs at this point. So what do you guys think of this one? What do you think the rhythm is on this one? This is number 7 in your stuff. So sinus rhythm. So first off, let's just say it's a probably a wide complex tachycardia, regular. And so someone said that says so sinus tachycardia.
Sinus tack to the left bundle.
So sinus tack with the left bundle. Is this VT? How about let's start off by saying that. Is this VT? So it's a wide complex tachycardia. Is it VT or is it sinus tack? Or atrial tack or some sort of atrial something?
Sinus tack isn't that clear Q waves and
Is the QRS that wide? It looks like 112 to me. No.
Yeah, for the sake of argument, let's call it 121. Like 0.121, so to make it wide.
All right. Yeah,
Just
I
no.
didn't think it looked that wide.
Yeah, no, you're totally right. It's just it's borderline wide,
Okay.
but let's just for the sake of argument call it wide.
All right.
Yeah. So do we see P waves? That's the first question.
Yes.
Okay. In what lead do you think you guys see P waves best? In lead 2. So you're saying that this is a P wave, P wave, P wave, P wave there?
I think there's some in V2 and V1.
In V2 or V1, right. So I actually, if we look at the V1 and we look at the rhythm strip here, this is actually where it's most helpful. And sort of my teaching point of this slide here has to do with this PVC. So the PVC helps unmask things for you. So you're going along, and I would say when I look at this, I'm not sure I see clear P waves until I get to this PVC right here. And with this PVC, now I can actually see P waves get unmasked. So that, especially right here, that's my P wave, and you guys will look at that and say, yeah, that really does look like a P wave. And so that is right here, that you sort of sometimes see and sometimes don't. All right, and then that P wave is right there. So this actually ended up being an atrial tachycardia with a left bundle branch block or incomplete left bundle or whatever you want to call it. But one of the things is use every lead, look for the P wave, look for these perturbations like a PVC or a PAC, and you might uncover things that you can't see otherwise. And I also know that this person had a pacemaker in place and we can interrogate it and we could match it up so I know what they had. But when you just look at this EKG, I think it's actually, you can just look at it and you can see it right there.
So it's just sinus tach?
This actually ended up being an atrial tach because the rate is pretty fast. But the point is,
Why that PVC? I mean, there's a little P wave before that PVC, and then there's another little.
and there's another little thing there, because this is the end of one of the P waves, and that's the beginning of the next one,
Okay.
and then that's the next one, and then there's another one buried in here, and then there's one there, and then there's another one buried in here, and you can't see that other P wave because it's 2-to-1 conduction.
So that's why you call this atrial tach.
Yeah. I also know that she's patient dependent in her atrium and normally and blah, blah. I know a lot of things about her, but the key is just that these PVCs, things can unmask things. All right, let's go to number 8. Let's read this EKG. Oh yeah, this is a fun one. So we'll say, so the rate, we'll say, is a little less than 5 boxes, so it's probably like, 50 beats or 55 beats a minute or so. Is this sinus rhythm? Is this not sinus rhythm? Is this heart block? Can you have sinus rhythm and heart block at the same time? Yeah, you can, because sinus rhythm is what the atrium is doing, and heart block is AV conduction. So first degree, can you have first degree heart block that's like 500 milliseconds? Yeah, you can.
Yeah.
Right, so this is sinus rhythm, or sinus bradycardia, with a really long PR interval. They also have a right bundle branch block. And they maybe have a left posterior fascicular block also. But when I see something like this, at least one of the things that's going to catch in my head is this P wave is like right in the middle of the 2 QRS complexes. So I'm just going to wonder, is there something buried in the middle here? So in this situation, I'm going to like take my calipers out and say, okay, is it possible that I see something halfway between this, and that halfway would be right here, and I don't really see anything? So PR intervals are normally, 120 to 200 milliseconds? But they can extend out to 500. I've seen 800 milliseconds. So you can have someone who's got such a diseased AV node that it still conducts through, but it takes a really long time. All right, so sinus bradycardia, significant first degree AV block, right bundle branch block, maybe left posterior fascicular block also. All right, number 9. So, I love this one. Asystole, 17 seconds, then heart rate of 20. RN aware. Is this asystole? No, it's not asystole. Now we're getting into semantics, by the way, but that's fine. So what's going on here? That's a good guess. what's the atria doing?
It's fluttering.
Right, exactly. So this is ventricular asystole, you might say, but this is atrial flutter with heart block. So it's an important thing. I mean, yes, it's like they had a 17-second pause. They need something to be done. But you want to be sure you don't miss the flutter and that you don't miss things like, does this person need anticoagulation or not? Do they need, well, I don't know, whatever else that you need to do with this. So this is flutter with heart block.
How often does this happen? I've never seen it.
Yeah, it happens. I'll say you're much more common. You don't see flutter as much as you see AFib, but you will see AFib with heart block. I know it seems like I'm perseverating on AFib with heart block, but like I assume you guys have a baseline level of knowledge, and so I'm trying to push you just a little bit above what I assume you already know. Obviously, I've seen this at least once in 6 years because I have a slide of it. All right, let's go on to case 10. What is happening here? I didn't do questions. These are just random ECGs I pulled from my stash for everyone to look at. Is this normal sinus rhythm? So yes, this is normal sinus rhythm. Is there anything else abnormal, or is there anything abnormal with this ECG though? Okay, so they have a left bunduloid. I'd have to sit there and measure. I don't know if it's 120 or not. All right, let's call it, sure, we'll call it wide. I don't know if it makes a difference or not for this. Normal sinus rhythm describes what's happening in the atrium. It does not describe what's happening in the ventricle. So what's happening in the ventricle? Or what's AV conduction like? Right, so let's go through and let's look. So P wave QRS, P wave nothing, P wave QRS, P wave nothing, P wave QRS. But this P wave, this PR interval is so short. Right, so that's not conducting from here to here. Or even if maybe it was, by the time you get to that beat, well, that PR interval isn't conducting. And even if you say, I really think it is, by the time you get to that beat, that PR interval isn't conducting. So you have PQRS, P wave nothing, PQRS, P. So this is not 2-to-1 conduction. This is normal sinus rhythm because the sinus rate is 90 beats a minute, but there's heart block here with an escape rhythm. Right, so this is another example of complete heart block. And the QRS rate is 1, 2, 3, 4, 5, 6-ish, so about 50 beats a minute or so. So this is one of those people that if they're stable and talking to you, you may or may not feel like you need to put a temporary wire in them.
So it's complete heart block, but you're still calling it normal sinus rhythm.
Yeah, exactly.
That's what's throwing me off.
Exactly.
I never would have called that sinus.
Right, but that's a key thing. So if I know it's like semantics, as I said, but especially for like the cardiologists, on their cardiology boards, the fellows, you would have to code this as normal sinus rhythm with complete heart block.
The sinus one's fine.
It's the AV node that's having a problem here, or the his Purkinje or something. And now you could go along and you could say, all right, well this is regular to there, to there, to there, and then you have something come in early. So this beat maybe conducts, like you get some random beat that conducts. But this is complete heart block, but this is, again, an example of if the patient's awake and talking to you, you may or may not put a temporary wire in someone like this. And you may say, gosh, let's get EP involved. Maybe they can put a pacemaker in this afternoon or tomorrow or whatever it is. All right. So to prove that I'm a general cardiologist a little bit of the time also, so here's the question for number 11. Which wall of the heart is involved in this abnormality? For whatever. This is case 11's EKG. So the primary abnormality is in the inferior wall, we have one person say. We have multiple people nodding their heads and agreeing. Right, so this person is having an inferior ST elevation MI. Right, so the STs are up here. You do have ST depressions in a lot of other leads, but those are the reciprocal ST depressions. So the primary abnormality is the ST elevation, not the ST depression. So if you have someone who's having an inferior ST elevation MI like this, what should your next step be? You've gotten this EKG, they're having an inferior ST elevation, you've called up the cath lab. What next diagnostic test do you want to do? You guys know what you're supposed to do for inferior ST elevations versus other ST elevations? Yeah, so you want to do a right-sided ECG on those people, specifically V4R, so the right side of V4. So V1R, V2, V3, V4. You want to look to see, do you have ST elevation in V4R? Because what are you looking for when you do that? Like, why do you do it?
To see if they're posterior.
Right, so an RV infarct. So you're looking for an RV infarct, because if they have an RV infarct, you're going to treat them differently. All right, you're going to try and maximize their preload. So instead of reducing their preload, like giving them morphine or nitrates, you're going to try and actually give them fluids, possibly, depending on the situation. Because the RV becomes stiff in the setting of an RV infarct, and it needs the preload. So inferior ST elevation MI, you want to be giving these people, you want to do the V4R to figure out how to manage them. Okay. So most commonly you're going to see an RCA lesion like that. You might also see, depending, it might be a left-sided circ or PDA lesion. So this person has a nice little thrombusy looking thing there. I know totally threw you that it wasn't an arrhythmia. You didn't even know how to handle that. All right. So this is a 42-year-old who comes in with chest pain. And what's the best treatment for this person? So do you want to give them, do you want to do a PCI and send them to the cath lab? Do you want to give them morphine? Excuse me, not metoprolol, excuse me. You can give them morphine also. But metoprolol, colchicine, or TPA? So I get a colchicine. Okay, that's one for colchicine. Yeah. Metoprolol, okay. Yes.
I changed my mind.
Okay. TPA. So we're
I'm just going to say go to the cath lab.
exactly. So we have 1111. All right. So I would give this person colchicine. So this is pericarditis. And no, not that one. So, so they have diffuse ST elevation. There's not one specific lead. And they have PR depression. So you can see PR depression here in lead 1. You can really see PR depression here, 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 here. So PR depression, ST elevation, and it's diffuse. It's not like it's in one, I don't know, anatomic or grouped segment of leads, contiguous leads. All right, so this person has pericarditis as their cause. So colchicine you could use, or NSAIDs, aspirin, ibuprofen, whatever you want to talk about. But someone like this, you don't want to give them TPA. You don't want to take them to the cath lab. Metoprolol you probably don't want to do because their heart rate is secondary to, their sinus tach is secondary to their pericarditis. So treat the pericarditis. So obviously there are people that go to the cath lab for things like this. At times. But the key is it's the diffuse nature of things, and it's the concomitant ST depression that you're seeing. And this is something that we do see also. That's not a random thing. All right. We're getting tired. We're getting actually sort of towards the end. I don't think we have 2 hours worth. Case 13, what do you guys make of this EKG? We're getting to some random things, but this is when it's fun. Yeah.
I always just end up going to whatever the strip at the bottom is.
Great.
Is there one in particular, like, should you do that, or?
That's,
you know?
it's a good, like, it actually is a pretty good like first pass thing, because you're going to get your rhythm. If you're just doing like the quick eyeball, you'll get your rhythm, you'll get your rate, and you'll get at least 3, if they give you 3 leads, you'll get sort of an orthogonal look of things. So it's not a bad thing to do. Sorry, what's that? Brugada? I've never heard of this Brugada. Can you tell me about it? Yeah, so this EKG shows sinus tach with a Brugada pattern. So that's really good. So do you guys see V1 through V2 or V3 here? So you see how this doesn't look like a typical right bundle branch block pattern. That sort of angle of the ST depression or ST elevation is, it's not as steep as you typically see with the right bundle branch block. We talk about this coved ST elevation here. So J-point elevation with a coved ST elevation. So this is a Brugada pattern. Somebody's got Brugada syndrome or Brugada pattern on an ECG. And I'll say that we randomly pick up ECGs like this 2 to 3 times a year. So you may see one in the unit at times. This pattern is variable. So someone may have it and then it may disappear on the next ECG. Things like fever might be more likely to bring it out, or certain drugs can bring it out. Cocaine can bring it out.
Why do you usually see it in V1, 2, and 3?
Do you want the complicated answer or do you want the easy answer? The easy answer is because the abnormalities so it's a sodium channel mutation, and the density of sodium channels is most prominent in the RV outflow tract, or in the RV, so that is most close to V1, V2, and you get these differences in the layers between the epicardium and endocardium, and that difference is most prominent in the RV area.
Sorry, what was the pattern again?
So
What am I?
look at these EKGs. So this is what the pattern is, but it's specifically that you go up in this angle. I could write over here. So when you think about a right bundle branch block in like V1, let's say, so you get the R, S, R prime. With a Brugada pattern, you may or may not get something like this, but then it goes like this. So you have a much more exaggerated angle right here with Brugada versus a right bundle branch block. Sometimes it's subtle, sometimes it's difficult to see. This is one that's a little bit more obvious. But just more than anything, I just wanted to be sure you guys have heard of Brugada syndrome. It's one of the things that people can get VF from. More common in Asians, so those from Southeast Asia. So there's this like sudden unexplained nocturnal death syndrome that is actually Brugada syndrome. And then there's these other names like Bagun gut and forgetting the other name in like Thai or Vietnamese that they have for these things. So just so you've heard of Brugada and you get this funny pattern. There's 3 brothers named Brugada, Joseph, Pedro, and Ramon, who like demonstrated this thing about 30 years ago now, maybe. All right. So let's say that last EKG was from someone who suffered a cardiac arrest and they are in the unit and you want to try and figure out what it is. Here's another ECG that you see of someone who suffered a cardiac arrest and you're trying to figure out why they had a cardiac arrest. So why do you think this person had a cardiac arrest? Okay, here, what did you just call me? Did you just call me a cutie? Feel a little uncomfortable. So QT, I think, is what she just said. It's a good thing I've known you for a while. All right, so yeah, the QT interval here is really long. Right, so this person has long QT syndrome. Okay, so they're in 1, 2, 3, 4, 5. So their sinus rhythm at about 60 beats a minute. But this QT interval here, if you sit there and measure it, it's, I don't know, almost 500 milliseconds. And because they're at 60 beats a minute, those correction formulas that you use, you don't need to correct at 60. Because when you correct it, your QT equals your QT corrected. So this person has long QT syndrome. They have a really, really long QT interval. And we do see these people also. Although, to be honest, a lot of them actually go to Harborview. So a lot of people have out-of-hospital cardiac arrest in Seattle, end up going to Harborview, and then they get transferred here for their defibrillator. But we do see the occasional person here. All right, so we're just going to do an interlude case. No questions. This is just sort of an interesting case. So a 53-year-old who has a biVICD, and he gets a shock while he's sleeping, and it wakes him up. And then over the next few hours, he hears his device beeping every so often. And he decides, I'm going to go to the clinic in the next few days. I want to go to church this morning. It's a Sunday. And he gets shocked 3 times in church. And finally, he decides to go to the emergency room after all of this. So you're just seeing someone in the ER, and you call EP, and it's 2 hours before I can get there. And so what do you want to do for someone like this, do you think? And he says, when you ask him, those 3 times I got shocked in church, I was fine. I was sitting there, and I just got shocked. I didn't feel dizzy. I didn't feel short of breath. I didn't feel chest pain. I didn't pass out. I just got shocked out of nowhere. All right, so let's just, I can't get there for a while, and let's say you don't know how to do it yet. So you're going to call the rep, and the rep. So I will tell you this: at UW, we don't have reps come, just as an FYI.
You don't?
No. So the EP service interrogates all devices here. Okay. So if you need a device interrogated, we do not have the reps come. We always have one of us interrogate it. All right. So you said magnet. Why do you want to do a magnet?
Well, if he's, ideally you have him hooked up and you can see that he's fine. And if it's truly an inappropriate shock, then the magnet will stop the appropriate shock, but you can still place it.
Okay. So exactly. So for defibrillators, if you put a magnet on a defibrillator, it turns off the shocking portion, but it leaves the pacemaker portion alone. With pacemakers, it makes them pace asynchronously, so they'll pace at whatever the program rate for that device is, no matter what is happening. All right, so that's your story of what you want to do. So your differential is going to be VFib or VTAC is sort of an appropriate shock, an inappropriate shock from Afib or flutter. Maybe it's an SVT or a lead or device malfunction or some sort of electromagnetic interference. So what you want to do also is you want to get a chest x-ray in the meantime, at least look to see is there anything very abnormal. And so there's nothing on that. And while you're waiting for the EP console fellow to come by, he gets shocked 3 times. And on this patient, the resident's note said, we watched the second and third shocks and he was in normal sinus rhythm at the time. So then in this situation, definitely what you would want to do is this. So here's a chest x-ray of a guy who had a lead fracture and he's got a magnet on top of his ICD. They did not do that for this. This is a different patient here. But it is a very, very miserable thing to get shocked as a general concept. And so it can be life-saving. And so you need it, you want to do it. But if you're getting shocked while awake, it's not very good. So you want to try and grab a magnet. On 5 Southeast, it's supposed to be kept at the nurse's station up front, the magnet. I don't know if you know where it is. It's not kept on the code carts, just as an FYI, because the code carts get changed. And so the magnets were getting lost because they clean them every so often. And in this person, when we interrogated their device, they have these warnings that say that they had these fail shock. There's this RV lead integrity warning. And when you actually look in the interrogation of what was going on for him, here's sort of his atrial lead on top, and then this is his ventricular lead, and there's just all this noise all over the place. And then unfortunately he gets this 30, well, you can't see down. Oh, I guess this doesn't work. How about we do this? All right, there we go. So here you get this, the shock down here, but all this is noise. Okay.
And the impedance too on his interrogation was like over.
Exactly, so the impedance here is over 3,000, good. So that tells you that there's a lead fracture if the impedance is that high. And then they also had this sensing integrity counter abnormality. Okay, so magnets, don't forget about magnets. All right, you won't see this very often, but it's just very cool, ECG. Do you guys know what this is called, or what you're seeing here? Yeah, so the QT interval here is really long. But the other thing here, I think I have seen this like 2 or 3 times in my career. So you see how the QT interval changes every other beat? So that's something called macrovolt T-wave alternans. If you see something like this, it usually means the person's about to go into torsade. So if you see something like this on telemetry, it's actually a very concerning finding. And
Sorry, what's changing every?
so you see the depth of the T-wave,
Oh, I see. Okay.
or you can see it here on the bottom also.
Yeah.
The QT interval is also getting longer on these beats.
Okay.
So this is someone who typically has either like a really, really bad heart failure or someone who's got really bad long QT syndrome or a few other things. But anyway, this is one of my favorite ECGs, so that's why I show it. All right, we have a couple more, getting towards the end. So I just thought we'd do just a little bit of pacemaker type stuff. So this is someone who has a pacemaker and it's programmed, so VVIR. So they're in Afib, they just are pacing in the ventricle, and they have rate responsiveness turned on. So depending on their how much they're moving or what their hemodynamic need is, their heart rate can go from 50 to 140. So what sort of problems do you think you're seeing on this EKG with their device? So non-capture, so good. So you're seeing right here non-capture that you have a pacing spike, but there's no QRS afterwards.
Seemed like it's sensing appropriately.
Right, and you're also over-sensing. So let's say if you look at from your first 2 beats on the top row, from there to there, that's slower than 50 beats a minute. Right, so you're pacing slower than the programmed rate, so it's also over-sensing. So there's multiple things wrong with this pacemaker. And that's it. So anyway, so they have something wrong with their, not the pacemaker, but the lead. And so you'll see things like oversensing, you'll see things like non-capture. Let's go to number 17 here. What do you think's going on here? Or is there anything going on here? I'll tell you, one of the reasons I'm showing this is because this was missed in the ER. Right, so if you just look at these 8 beats or 7 beats, everything looks fine. But if you look at these 5 beats here, or 6 beats or whatever it is, you have non-capture on these. Right, so you have a pacing spike but no QRS, and then it starts to pick up here again. So look at all 12 leads, or look at all, and look at all 10 seconds.
What did they call it?
Oh, they just did the ECG because they, for whatever reason. He actually, I think he came in with passing out or syncope or something like that, or pre-syncope. But they missed this initially.
Well, it looks like that. 1, 2, 3, 4. One from the left.
That
Looks like it
or that?
maybe is like a type of, no, one over. Maybe fusion. No, sorry, to the left.
Either one of the, not.
But no, I guess.
This is just a pacing spike.
Okay.
Now, because you know the QRS looks like this,
Yeah.
right? So you should see something more here. So you have a P wave, and it senses the P wave appropriately, and it paces appropriately. It just doesn't capture. So there's not enough energy that the pacemaker is delivering, and it's right at that threshold. So the amount of energy you're giving is just at the level that it needs, that sometimes it works and sometimes it doesn't. Or maybe this is even respiratory. So maybe that lead moves just a little bit and it gives enough energy at one angle as you're breathing, but not enough as you're exhaling or something like that.
Who overreads all the EKGs?
Who reads them?
Who overreads them?
Cardiologists, whoever's on the cardiology consult service or others. All right, so I'm going to tell you right now, this is a really tough one I'm about to give you, but it's the last one. So it's a perfect time that it's the very end and we're making it more difficult for you. So this telemetry here, so this is, gosh, this was like a 25-year-old who had, I think he had some sort of congenital heart, no, he had a cardiomyopathy, he had really bad pulmonary hypertension, he was on like Flolan or one of those, he was in the unit. It's actually really sad because he ended up dying in a couple days afterwards. So the question is, what does this strip show? So is this a sinus arrhythmia, sinus bradycardia, sinoatrial exit block, or PACs? The answer, of course, by the way, has to be sinoatrial exit block because that's the only one you've never heard of. Right, and if I said it was the last one, it was really tough. Come on, you guys are good test takers. You've made it this far in life, right? And so, isn't that what this is going to be?
I feel like you're tricking us
I know, exactly. Mind games.
Sinus bradycardia.
So we'll tell you. So this is sinoatrial exit block, okay? So, sinus arrhythmia is just with the respiratory variation, the P wave rate sort of gets faster and slower and faster and slower. All right, and what were the other options there? So sinus bradycardia is just you have a constant PR, or constant PP interval, a constant sinus rate. PACs, this could be frequent PACs, but with PACs, the P waves should look different than the sinus one. The morphology should look different. So what this is that you have a P wave, and then your next P wave is here, and then you have P wave, P wave, P wave. But there's sort of this pattern of like every 2 beats or every 3 beats, but you always have a P wave before the QRS. Okay. And so what's happening here, if you look at the classic ladder diagram, so you have a spot within the sinus node. It's sort of, frankly, it's sort of like Wenckebach of the sinus node, is what we're seeing here. So you have a spot in the sinus node. I'm going to do it this way. And it takes a little time to get out of the sinus node. And when it gets out of the sinus node, that's the P wave that you're seeing. And then it goes through the AV node and the ventricle. And now the amount of time it takes to get out of the sinus node starts to extend. And it starts to extend, and eventually it blocks, and so you get no P wave. And then it gets shorter again. So the amount of time between where it starts in the sinus node and gets out into the rest of the atrium progressively gets longer. So someone like this, you may put a pacemaker in or not. I'll tell you, we see this, like our EP service sees this like once a year. It's not a very common thing. But, you know, as I said, it's sort of fun. All right, that's what I got. Questions, comments? You're tired, yes?
I'm really into what
Yeah.
here, but why can bradycardia lead to VTAC or like snoring?
Yeah, so, and that ties into the polymorphic VT and giving people isoproterenol or pacing. So there are these bradycardia-induced VT, and it has to do with PVCs. So when you get bradycardia, your QT interval is a little bit longer, and if you get a PVC that comes in at the right time, you can sort of get one of those R on T type things and induce VT. It doesn't happen as much when you're tachycardic because the QT interval is shorter, so it's more difficult for a PVC to cause you to go into VT. So it has to do with the duration of the QT interval with the bradycardia. All right, you guys did awesome, actually. That was really good.
That was a really great talk. Thanks,
So,
Jordan.
yeah, no problem.
Thank
Thanks.
you.